Hi, my name is Farnoosh, and the title of my poster is Empowering Physicians to Discuss Climate Change with Patients Whose Health is Affected by It. More recently, patients are beginning to develop symptoms that are attributable to climate change. Physicians are in a position where they can discuss these symptoms with patients, attribute them to climate change, and provide them with actionable steps to improve their health. In this poster, we delineate three different scenarios. Scenario one being allergic rhinitis, scenario two, asthma, and scenario three, insomnia, and provide sample script responses for what the patient physician dialogue might look like. In the first scenario, a patient who's never had allergies before develops them all of a sudden. And some actionable steps for this patient include beginning to check pollen counts on a daily basis, taking antihistamines prior to symptoms developing, and supporting organizations that will advocate on their behalf. In the second scenario, a patient with longstanding asthma now has more frequent exacerbations with no identifying trigger. It's likely that this could be due to climate change, and some actionable steps for this patient could be living away from a major street if they plan on moving in the future, as well as limiting driving during rush hour and checking the air quality forecast on a daily basis. In patients with insomnia, they may not realize that rising temperatures during the day could also lead to increased temperatures at night and that this could influence their sleep quality. Overall, climate change is not routinely taught at every medical school in the country. There is a rising push to include it in the curriculum. However, as of now, it is not required for all medical schools to teach it. Given the impact that climate change is having on our world, on our country, and on our patients' health, it is incredibly important for us to understand what specific symptoms climate change causes and how we can counsel our patients about these climate change symptoms. Furthermore, climate change tends to be viewed as an abstract concept, and being able to correlate this abstract concept with tangible, concrete symptoms is very powerful and allows patients to truly grasp what kinds of effects climate change is having, and specifically what kind of effects climate change is having on their health. Thank you very much. I hope this was informative and appreciate your time.
Hello, everyone. My name is Sarah Shu, and I'm a medical student at Brown University. I will be presenting my research titled Dumpster Diving in the Emergency Department, Quantities and Characteristics of Waste at a Level 1 Trauma Center. So for background, the US healthcare system generates 10% of all US greenhouse gas emissions, and it generates nearly 4 billion pounds of waste per year. Yet, Hi everyone, my name is Sarah Shu. I'm a med student at Brown University, and I'll be presenting my research titled Dumpster Diving in the Emergency Department, Quantities and Characteristics of Waste at a Level 1 Trauma Center. For background, the US healthcare system generates 10% of all US greenhouse gas emissions, and it contributes nearly 4 billion pounds of waste per year. Yet while there have been many studies about reducing OR or hospital waste, there are actually no prior studies of ED waste audits. And so for our study, we wanted to quantify the waste generated by the ED, identify deviations from waste policy and areas for diversion, and finally, we wanted to calculate the emissions from ED waste disposal. And so to do that, we conducted a 24-hour waste audit of all solid waste, regulated medical waste, and recycling waste at the ED of a Level 1 trauma center in July of 2019. We then manually sorted all the waste into separate categories based on predominant material and weighted. The categories are on the right. We also tracked deviations from waste policy using the hospital's infection control manual and state regulations. For example, state regulations say that if waste contains blood products that are in liquid or free-flowing state, then that goes into regulated medical waste. If it is not saturated or dripping in blood, then that goes into solid waste. And what we found was that in a single day, the ED generated 1,481 pounds of waste, or roughly 4.4 pounds of waste per patient, and roughly 10% of that was medical waste. When we broke down the waste by material, we see from these red and blue bars that over 60% of the waste was some form of plastic. And in the medical waste bins, we found that nearly 85% of waste thrown into the red bags was not medical waste. This is concerning because medical waste actually costs 5 to 10 times more than solid waste to dispose of and generates more pollutants than solid waste disposal. We also found more than 200 unused and unopened items, 30 unopened Diet Cranberry juices, and someone even threw a brand new trash can in the trash can. And finally, we estimated that 1 day of waste disposal generated the same CO2 equivalents as driving a car 7,700 miles. And so to conclude, the ED generates significant amounts of waste, and there are many ways ED waste disposal can be improved to reduce waste, increase adherence to waste policy, and reduce environmental impact. Thank you so much for listening.
So our project was titled Applying a Structural Competency Lens to Teach Medical Students About Social Determinants of Health. So as we know, so decades of research on health disparities point to social inequalities in driving poor health outcomes. And today, as we also know, that COVID-19 has laid bare the unequal healthcare access and treatment in our society, which further has exacerbated the already existing disparities that we have. And one thing that we've come to realize over these last couple of years is that the root causes of climate change and health inequities overlap. Impacts of climate change are not fairly distributed, and climate change exacerbates existing social inequities. So addressing upstream drivers like structural racism will in turn address climate change and health inequities. And we feel that it is crucial to better educate and inform the incoming medical students and incoming healthcare providers about these issues as well. So we use the structural competency lens, which is defined as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, and diseases, how they also represent the downstream implications of a number of upstream decisions about such matters as healthcare and food delivery systems, for example. So through that lens, we sought to teach students about social and economic forces that contribute to disparities in health. So how we went about that was we used, it was an online updated version of an already existing in-person session. And the structure of that session was as follows. We assigned a pre-assignment to the students in which they used data from the New York City Community Health Profiles to examine the following parameters in looking at Brownsville versus Park Slope, which are two areas that have historically and systemically been affected by various things on the opposite ends of the spectrums in terms of health inequities. We also use a standardized patient interview in which a near-peer facilitator played the role of a middle-aged woman with uncontrolled type 2 diabetes, and students were tasked with gathering a social history. And finally, we used a group exercise in which students were tasked with describing potential solutions at different levels of the social ecological model to improve her diabetes-related outcomes. And participants were asked to complete a pre and post survey about their importance and their confidence in the issues that we talked about during the session.
Through analysis of the pre and post survey, which 123 of our 210 participants completed, we found that there was a statistically significant increase in reported comfort with the competencies that we discussed and an increase in the perceived importance of the topics that we covered in relation to medical education for all but one of the questions. And that question was the importance that students placed on incorporating social determinants of health into medical education. And the only reason there was not a statistically significant increase pre versus post session was because students already reported that this was highly important to their medical education. In the case of all other questions, including whether health disparities experienced by diverse racial and ethnic groups were well understood by patients, if they understood historical and contemporary impact of racism, bias, prejudice, and discrimination in healthcare, if they understood the relationship between clinical systems and social symptoms and social, political, and economic systems, and whether they were comfortable with coming up with treatment plans that took into account any structural issues in a patient's life, as well as whether they felt that education about systemic racism and racism in healthcare and education on structural competency were important to their medical education. Students did report a statistically significant increase in the rating they placed on these topics. And this indicates that these types of sessions are extremely important and effective, as well as valued by medical students coming into their medical education.
And these findings show that the early exposure of this session provides knowledge to systemic issues that students may have had before, but they still see an importance in learning that. And those who hadn't find more increased perceived importance of that. And therefore, these sessions should be part of, are an important part of future medical education. We had some limitations that we utilized New York specific data, which may not be available in other places of the country. And also there was some the fact that the survey was self-reported is also a limitation. But overall, we were able to show that that this kind of session has an important role in future medical education, as these systemic injustices are issues that are increasingly important in one-on-one patient care.
Especially given the growing threat of climate change and the role that climate change plays on exacerbating existing social inequities, as highlighted by COVID-19 and its disparate impact across the United States.
Thank you.
Hello, my name is Margaret Patella, and I'm a second-year medical student at George Washington School of Medicine and Health Sciences. This is a literature review of the intersection of climate change, wildfire smoke, and COVID-19. Wildfires have gotten significantly worse over the past decade due to climate change creating hotter and drier weather, especially in the American West. Figure 1 in the lower left corner shows the increasing number of acres burned in California in the last decade. 2020 was the worst fire season in California's recorded history, with double the number of acres burned as the next highest year, which was 2018. Oregon and Colorado also had record-breaking fire seasons. The photo just above the graph was taken in San Francisco. It shows just how much smoke was in the air due to the wildfires in early September. Recurrent wildfire smoke inhalation has a number of demonstrated health effects. The most obvious are respiratory irritation and exacerbations of asthma and COPD. Less obvious impacts include cardiovascular disease and adverse pregnancy outcomes. Unfortunately, many of the health impacts from wildfire smoke are also risk factors for severe COVID-19. The table in the middle of the poster shows a summary of the health impacts of wildfire smoke and how they overlap with COVID-19 risk factors. The best way to avoid smoke inhalation is to evacuate to an area with better air quality. However, this was made difficult by COVID-19. In the past, many people have relied on friends or family for a place to stay. This was inadvisable during the pandemic, so evacuation plans needed to be changed. And in a year when many people lost their jobs, the funds to safely evacuate may have been absent. In a historic year of pandemics and apocalyptic-looking skies, the health and public safety systems were required to respond to multiple coinciding disasters. Overburdened systems are less able to respond to either disaster effectively, making the most vulnerable populations at even more risk. Social and economic factors often prohibit relocation for those most at risk of recurrent fire and smoke exposure, making it likely that these same individuals will be exposed to wildfire smoke year after year, and thus increasing their likelihood of negative health consequences. The same exposure will worsen the general health of the area and make that population more susceptible to chronic disease and emerging pathogens. It is vital that the factors that are compounding upon these vulnerable populations get addressed, including climate change, worsening environmental health, and health systems issues that are negatively affecting these populations. Unless something changes, the negative impacts of climate change on health will affect.
Hi there. So this project was focusing on developing methods to map electricity-dependent patients who would be at risk of flooding and power outages in the event of adverse weather events in a coastal city. So we use nebulizer patients as a subset of the electricity-dependent population. And our first step was to create a list of these patients from the medical record, and then use publicly available census data layers in ArcMap to create a heat map of where these users are located at the tract and block level. And so the next step was to overlay hurricane and inundation zone maps to find out what tracts and blocks are at risk in any category of hurricane. And this is displayed in Figure 1, where tracts and blocks with different frequencies of nebulizer users are displayed with lighter colors indicating fewer nebulizer users at risk in that tract compared to darker colors with higher numbers at risk. And so the next step was to then stratify the blocks at risk by hurricane category to determine, for example, how many patients would be at risk from a Category 1 storm compared to a Category 4. And so when we looked at the proportion of patients at risk, we found that 521 nebulizer users, which is 25% of this population at this hospital alone, are at risk of flooding during a hurricane. And a Category 1 hurricane alone would put 186 patients at risk. So you can see that these really are a potential contribution to emergency department usage in the event of a disaster due to interrupted access to power at home. And so our findings really suggest that these patients would benefit from emergency preparedness counseling, and our approach is simple enough to be adapted to a wide range of DME categories and environmental hazards to identify other subsets of the electricity dependent population, or what other hazards pose a risk to their power supplies. And so our methods are also easily reproducible at any other healthcare organization, and as such can be used to identify both patients in need of support in the face of local climate-related hazards, and also to support emergency resource allocation in anticipation of a natural disaster. Thank you.
With terminal waste disposal being a critical player in environmental pollution and the production of greenhouse gas, steps to reverse waste are critical. At the University of Texas at Austin's University Health Services, we have implemented general recycling, nitrile glove recycling, as well as compost streams. These measures have helped the UHS divert about 68 pounds of waste each week. However, contamination has resulted in environmental and financial costs when our waste partners return shipments due to contamination rates, resulting in waste ultimately going to the landfill. This study, through a survey, sought to better understand clinical staff attitudes for sustainability and barriers to adherence to clinical waste disposal protocol so that we can improve current practices and so that we're better prepared to engage with future healthcare sustainability initiatives. With both the Likert scale and free response questions, the compiled fishbone diagram helps us break down the individual factors contributing to that contamination. A recurring theme was that the main barrier to adherence wasn't understanding the importance of sustainability, as 97% of staff indicated favorable attitudes, but rather logistical barriers that made sorting waste more difficult than desired. While signage, training, and bin setup changes can help divert waste, once it has been produced, seeking ways to mitigate waste production in the first place seems to be the optimal approach, and it will at the same time satisfy the indicated clinical staff desire to make clinical waste disposal less staff intensive. This can be accomplished by removing non-value added processes, using sustainable alternate materials, and continuing the implementation of telehealth. To remove non-value added processes, we plan to map out what are the steps in care delivery and see which steps generate waste. And if that waste doesn't need to be generated, it can be cut. For example, in the past, UHS opted out of mandating exam table paper, so now it is not used in fully clothed patient visits. And also with the advent of the pandemic, UHS transitioned nearly all initial appointments to telehealth, with an in-person follow-up used as necessary. Telehealth presents another avenue to remove waste, as less resources and emissions are generated through these remote visits, seemingly without a dip in quality, as 98% overall satisfaction was reported by patients this summer for care delivered in that medium. This begs the question, even after the pandemic, what processes can be kept virtual? Why revert if that doesn't hinder the quality of care? And in many cases, it makes it much easier for the patient and provider. Lastly, using alternate materials that are less resource intensive can reduce the lifestyle impact of healthcare delivery, or having clinical materials that are in their entirety go in one stream or having its own processing stream. Each of these approaches will help reduce the amount of terminal waste while making the entire process easier for staff and more comfortable for patients. Overall, this survey gave us more insight on what staff has preference for and what they value while they feel burdened, which can help us be considerate of healthcare professional needs when implementing any future healthcare initiatives in sustainability.
Thank you for your consideration of our abstract entitled Investigating Air Pollution as a Contributor to Health Disparities During the COVID-19 Pandemic. My name is Natalie Rousseau, and I'm joined by my colleagues from the GW School of Medicine and Health Sciences, Soumya, Caitlin, and Harleen. The high rates of morbidity and mortality from COVID-19 among minority patients, particularly Black patients, has been of ongoing concern in medicine and public health. Research suggests that disproportionate exposures to both the virus and causes of underlying chronic illness underpin these disparities. However, the role of air pollution as an environmental determinant has not been fully explored. Race is a significant predictor of living in a polluted area within the United States, and prolonged exposure leads to chronic inflammatory stimulation, even in young and healthy people. Emerging evidence increasingly suggests a relationship between exposure to air pollution, increased inflammatory stimulation, and adverse outcomes from COVID-19.
Thanks, Natalie. In this analysis, we conducted a primary literature review exploring evidence regarding the relationship between COVID-19, race-linked health disparities, and atmospheric pollutants. Exposure to sustained elevations in air pollution has been associated with an increase in type 1 inflammatory cytokines, which suggests that air pollution can drive a type 1 inflammatory state. The severity of COVID-19 infection has also been associated with a heightened type 1 inflammatory state. High serum levels of type 1 cytokines, IL-1, IL-6, and TNF-alpha, as well as T-cell lymphopenia, have been seen in COVID-19 patients requiring hospitalization, ICU-level care, and developing ARDS. Thus, air pollution may contribute to the underlying health conditions which make individuals more susceptible to severe COVID-19 infections, conferring an additional stressor on minority communities.
Based on our primary review of the literature, we have identified 4 points for consideration in future research. 1. Factor air pollution into future respiratory health studies. 2. Launch a national research initiative collecting data on disparities in COVID-19 severity as it relates to local baseline air pollution levels. 3. Evaluate short and long-term impacts of air pollution on number of COVID-19 cases and severity in the context of public policy changes. And finally, trend air pollution levels across the nation in relation to COVID-19 outcomes.
In order to better address health inequity, particularly during this pandemic, this review demonstrates why environmental factors such as air pollution need to be addressed in conjunction with other contributing factors. Though race is often cited as an independent risk factor for poor outcomes in respiratory diseases, it is better understood as a composite rather than essential variable. Care must be taken not to conflate social and environmental factors that disproportionately impact communities of color, including air pollution, with biology. Thank you for your consideration of this review.
Hi, Happy New Year. This poster is titled The Children of Superstorm Sandy, Limbic Circuit. I'm Jessica Buthman, a doctoral candidate at the Behavioral and Cognitive Neuroscience program at the CUNY Graduate Center. My expected graduation date is this May, so I am currently seeking a postdoctoral research position. Please reach out if you are hiring. Thank you for your interest in my poster. I have had the good luck to be part of an NIMH-funded birth cohort study following children who were prenatally exposed to Superstorm Sandy. The study also includes children who were born before the storm occurred. In this study, I compared some neuroimaging data I was able to collect from these two groups before the COVID-19 pandemic halted study activities. 14 6 to 8-year-old children came to CUNY's Advanced Science Research Center MRI facility for scans. We obtained structural, diffusion-weighted, and resting and task-based fMRI data. With training, all of the children were able to complete the scans, with the exception of 2 who fell asleep. Our analyses focused on the prefrontal limbic circuit, which underlies emotion regulation processes. Prior research indicates that this circuit is abnormal in people who have been exposed to early life stressors and/or have symptoms of emotion dysregulation, such as anxiety. Structural analyses comparing regions of interest in the control children and storm-exposed children show that prenatal storm exposure is associated with larger bilateral hippocampi and amygdalae, marginally smaller left lateral orbital frontal cortices, and smaller right parahippocampal gyri. Our fMRI task was adapted from Hariri and colleagues from 2002. Children matched a picture on the bottom to the picture on the top by pressing a button. The pictures were either shapes or faces displaying scared or angry expressions. Analyses indicated that bilateral amygdala activation during face matching blocks was greater in children who were prenatally exposed to the storm when compared with controls. Abnormality in the prefrontal limbic circuit may indicate risk for the development of disorders like anxiety and depression, or subclinical impairment. Following the busiest hurricane season on record, and now during a global pandemic.
Hi, my name is Madeline Scolio, and I am a sophomore at Villanova University. I'm here today to introduce you to the research on climate change mortality that I've been working on alongside Dr. Ruth McDermott-Levy, Dr. Kavindra Shakya, and Caroline Hallen-Moore over the past year. To begin, I would like to briefly explain the importance of this topic. As I'm sure many of you are already aware, the effects of climate change and climate change-related events are widespread and frequent. Currently, there are no set parameters that are able to determine whether a death can be attributed to climate change. Our work aims to identify the parameters of climate change-related mortality so that the extent to which climate change has already and will continue to affect human health can be better quantified and understood. In order to do this, we conducted a systematic review using 3 databases, PubMed, Web of Science, and Scopus. In these databases, we began by using the search terms climate change, mortality, United States, and human. We then limited our search excluding anything with the keywords plants, trees, Europe, economics, and policy, and then further limited these articles to only ones that were published in the United States between 2010 and 2020, and also in English. After manually going through and reviewing all of these articles, removing any duplicates, and then taking out any that were deemed irrelevant, we were left with 119 articles that are included in the review. While most of this literature primarily focused on heat-related deaths, other factors such as extreme cold, accidents and injuries, poor air quality, precipitation and flooding, drought and wildfires, infections, vector-borne diseases, the influence of comorbidities, and mental health, including suicides, were also influenced climate mortality. Further, we also found that a variety of social and demographic factors, such as race and ethnicity, geographic location, gender, socioeconomic status, age, and occupation, can increase vulnerability to climate change mortality. Our research demonstrates the extent to which climate change has already begun and will continue to influence human health. Further, it also demonstrates the needs for the development and implementation of a system of parameters that will allow us to accurately measure the scope of climate change's impact on human health and the variety of complex ways in which these impacts manifest themselves. Thank you.
Hello everyone, my name is Marianne Itzhak-Sadeh, and I wanted to briefly present our poster about the effect of prenatal temperature and PM2.5 exposure on birth weight, looking at weekly windows of exposures throughout the pregnancy. Birth weight is a strong predictor of normal growth, healthy development, and survival. And several studies have found associations between temperature and particulate air pollution and birth weight. But the relevant timing of exposure varies between studies and is still unclear. So in this study, we wanted to assess the difference in term birth weight associated with weekly exposures to temperature and PM2.5 throughout 37 weeks of gestation. We included all singleton live term births in Massachusetts between 2004 and 2015. And we utilized a distributed leg nonlinear model to estimate the difference in birth weight associated with these weekly exposures from the last menstrual period to 37 weeks of gestation. In figure 1, you can see the distributions of the mean temperature and mean PM2.5 exposures over gestation. We included about 700,000 births. The majority were white mothers, and the mean term birth weight was 3.4 kilos. Figure 2 shows the cumulative exposure response curves, which shows the net effects of the exposures across the entire leg period. You can see that for colder temperatures, we observed a positive association with term birth weight, and for hotter temperatures, we observed a negative association with term birth weight. For example, for the 5th percentile of temperature, which is -4 degrees, the cumulative difference in term birth weight for 1 degree increase in temperature was an increase of 2.5 grams. On the other hand, for temperature in the 95th percentile, which is 23 degrees Celsius, the difference in term birth weight associated with 1 degree increase in temperature was 7.7 decrease grams. For PM2.5, we also observed a negative association with PM2.5, and the cumulative difference in term birth weight associated with 1 micrograms per cubic meter increase in PM2.5 exposure was minus 3.9 grams. Figure 3 shows the difference in term birth weight for temperature at the different percentiles and for PM2.5 across the different weeks of gestation. And you can see that for temperature, if you look at figure 3b, we observed stronger effects in the first weeks and last weeks of gestation. And for PM2.5, if you look at figure 3c, you see that the stronger effects were at the final weeks of gestation. So in conclusion, we found heat and PM2.5 exposure to be related to lower term birth weight. Our findings suggest that women are more susceptible to both exposures toward the end of pregnancy. And also susceptibility to heat was higher in the initial weeks of pregnancy as well. Thank you.